standing by to let you back in the waiting room. I think those are all the tips I have for you today. Anyone else from the tech team? Did I miss anything?
The only thing is if you're calling in only and don't have a video, you will not be able to change your name as it appears on the screen. We'll just see a phone number. So if you have the option of joining by video as well, that would be awesome.
All right. Oh yes, I also want to remind you of Whova. Whova is the platform, the application that you're invited to register for and sign on. And there you'll find a whole bunch of information about the summit, including presenter profiles, presenter presentations, profiles about the other attendees, and there'll be some conversations going on that we invite you to participate in. You can still sign on to that application. You will receive the information in emails about the summit. So with that, if there's no other tech tips I need to share, I would like to, I just want to check in with Greg. We're good with all those things? I'm going to say yes. So let me invite up next.
Yes, we're good, sorry.
Okay, so I want to invite up Linda DeSantis, who is going to help moderate today's summit. And many of you, I'm sure, know Linda. She has over 25 years of experience working in STD and HIV prevention. She was at DIS in San Francisco over 20 years ago, and she's currently a program manager for the California Prevention Training Center and has been intimately involved in planning the summit. And she's going to welcome you and kind of set the stage for today.
Well, great. Thank you, Eileen. Next slide, Greg. So I just want to give a big welcome and a good morning to everyone. As Eileen mentioned, I know many of you. I'm Linda DeSantis. I was a former DIS in San Francisco a very long time ago. That was when we almost eradicated syphilis. And I've been deeply involved in the planning of this summit. So there's been a team of us actually working on the planning committee for this. So I want to give them a shout out and I want to invite them to say hello so that if each person would unmute themselves, say hello from their branch and section when I call their name, that would be great. So we get an idea of who's on this team. So I want to welcome Pike Long.
Good morning. Hi.
Charisse Kemp.
Hey, good morning.
Matt Willis.
Good morning, everybody.
Brett Augsjust.
I don't see Brett yet.
Okay. Edwin Lopez.
Good morning.
And Jessica Frazier-Williams. So she may not be here either.
She's on COVID, sorry.
Yeah, I just want to acknowledge that many people are reassigned. And so acknowledging that, I think many of you know this was to be an in-person meeting summit for over 3 days in Oakland this past June, but we all know why it got canceled in late April. COVID hit, and now we're all dealing with how it changed the way we do everything, which is why we're here in this virtual room for our summit. I also want to acknowledge that COVID is only one piece of what is currently happening. There's political tensions, racial injustices, environmental crises happening. Particularly, we're in California, so we have fires and the smoke. And I want to recognize we're balancing our personal needs or challenges with those of our family, our clients, our communities, colleagues, and the programmatic demands. So it's really a lot. So the timing for this might not be perfect, but perfect is a lot to ask in these days. So we couldn't wait any longer. So given all this, given all that you're holding and all that's going on, I really am so glad you're here. And I'm really excited for what we have in store for you. And I'm hoping that you get excited too. So with that, I want to hear, because we're such a large group and we're doing this virtually and we can't give each other our hugs, we're going to do some polls. So Greg, if you would launch this, we want to find out where people are located. Are you in the North Counties, anywhere north of Sacramento? Are you in the Bay Area? Are you in the Central Valley? Or are you in the South Counties? Let us know where you're calling from. And I see the polls coming in. I see some responses. We're at 45%. Let's get practice for November. Let's get out the vote. 53%. Come on, people, tell us where you're from. Well, it's slowing down at 59%, and we tend to like to look at about 80, but we've got a lot to cover today. So Greg, maybe we give it a few more seconds and then we're just launching. We have another opportunity to get out our vote.
We have a lot of folks on the phone, so they can't.
Yeah, if they're on the phone.
Oh, thanks for that reminder. Okay, so let's launch our poll and see what we've got. Well, hopefully we're sharing those results. We've got South Counties taking the lead here at 41%, Bay Area at 24, and Central Valley at 25, followed by North Counties at 10. Welcome, everybody. We have people, this is a statewide meeting, and we're excited to have you all here. So let's go to the next poll. Now we're just looking at, how long have you been doing this work?
Sorry, I think I'm.
Have you been, how long have you worked in this field? We can just launch that poll. Is it less than a year? 2 to 5 years? 6 to 10? 11 to 19? Or 20 plus? We are curious who is here and how long you've been doing this work. We've got some fast votes coming in. We're at 56%. Let us know. We'll be mindful of people who are calling in and not on the computer. And let's see. Right now, taking the lead are people less than a year, 60%. I see it like forever. Well, it does feel like forever, but in actual years, let's figure out how long you've been doing it. And I'd say, Greg, let's launch the results. So the majority right here is less than 1 year, 38%, followed by 2 to 5 years. Wow. Close thirds are 11 to 19 and 6 to 10. And in the minority are people like me at 10%. So anyway, we welcome you. We acknowledge the efforts and the work that goes into all of this, and we're really happy to have you here. Next slide, please. We have some guiding principles that are, that really monitor our work. And like all public health conditions in the past, we know that communities who are most affected by STDs, HIV, and now COVID-19 have been disadvantaged for generations due to social and political discrimination, economic inequality, environmental conditions. And so it really prevents people from achieving optimal health. To public health means that we believe that all people deserve an equal chance to be healthy, regardless of their race, ethnicity, income, sex, religion, sexual orientation, gender identity, or disability. And we hope that these principles guide our summit. Our collective commitment will help move us forward to attaining a vision of public health that is equitable. And since today we're honoring the passing of Ruth Bader Ginsburg, I just want to acknowledge that she has a strong legacy with the American civil liberties. And that impacted all of us. It continues to impact all of us in our communities. So a quote that I read this morning was, "I try to teach through my opinions, through my speeches, how wrong it is to judge people on the basis of what they look like, the color of their skin, whether they're men or women. And I think we can extend that to the people that we're working with in our, our brothers and sisters across all the boards. So let that guide us today. And I'm into quotes. So another quote, Greg, the next slide, that has spoke to me as preparing for this summit was, I read this the other day. It's a quote by Toni Morrison. And it really speaks to me of the resilience, so I want to share it with you. I know the world is bruised and bleeding, and it is important not to ignore its pain. It's also critical to refuse to succumb to its malevolence. Like failure, chaos contains information that can lead to knowledge, even wisdom, like art. And so this quote spoke to me about resilience. And I know many of you, we've worked together for a long time, and I know the resilience that many of you possess. We're in a challenging and chaotic time, and it requires a level of resilience. So I want to encourage you to stay strong and stay vigilant. We have to rise and do the best that we can, and I know that you are doing that. So what's in store for us over these next couple of days? Next slide, please. We have our DIS virtual series agenda. So today we're going to be talking about the national and global perspectives on the expanding and changing roles of DIS. We'll hear from our chiefs at our state branches. We'll hear from Dr. Gail Bolin and Dr. George Rutherford. Day 2, next click, we'll be talking about medical mistrust, implicit bias, and cultural humility. And we'll have Dr. Oni Blackstock speak to us in a presentation, followed by 2 separate breakouts on motivational interviewing and cultural humility. And then finally on day 3, we'll be talking about boundaries, resilience, self-care, and moving forward. Shannon Weber and Anshe Hall Everett will be leading us through some activities. We'll be speaking with a panel of your colleagues to hear more about how things are going in several jurisdictions throughout the state. Next slide, please. So now I'd like to introduce the California Prevention Training Center has been working in collaboration with the STD Control Branch and the Office of AIDS. And here to speak with us this morning, Kathleen Jacobson, and she is the chief of the STD Control Branch. And she'll be speaking on behalf of both the Sexually Transmitted Disease Control Branch and the Office of AIDS, Dr. Marissa Ramos, who couldn't be here today. So now I'd like to welcome Dr. Kathleen Jacobson.
Make sure Kathleen's off mute there.
I'm not sure if anyone from the planning committee is on, or if Dr. Kathleen Jacobson is on.
So I'm not seeing her on the participant list, so maybe we can move on, and then when we see her, we can invite her to say a few words when she comes on.
Yeah, she has not logged on.
Yeah.
Okay. Well, I would see if anyone from either of those, we can move on, but if the Charisse or anyone is interested in, no. Okay. Well, I'll take that suggestion then, that if and when she logs on, we have welcome her to say a few words. So the next slide. So now then I would like to introduce someone who you probably already know, who I know believes in the resilience of DIS. She's one who views DIS as critical to the public health workforce, and that is Dr. Gail Bolin. Dr. Bolin is the director of the Division of STD Prevention, the Centers for Disease Control and Prevention. She is a leader in the field of STD prevention. She has spent her career committed to bridging science, policy, and program, making programs more evidence-based, and science and policy more programmatically relevant. Through her 40-year career, she has had the unique opportunity to work at the local, state, and federal levels of public health. From her first position at the San Francisco Department of Public Health STD Director to her current role as CDC's Division of STD Prevention Director, she has strategically used her perspective to drive STD innovation and science. Her passion and dedication are always apparent, and she is always ready to face new challenges in the dynamic and diverse field of STD. Our California PTC staff have worked long and hard with Dr. Bolin, and personally, she has been a great mentor to me. I worked under her when I was a DIS at City Clinic, then again at the CAPTC when I was hired to develop the PCRS training over 20 years ago. Her dedication to STD prevention and her ability to multitask is unlike anything I've ever seen. I'm honored and privileged to be welcoming her here today in this virtual arena, but I do miss running into her at airports or on airplanes, and I look forward to a return of those days again soon. So welcome, Dr. Bolin.
Hang on, let me get her slides up.
Oh, we're starting at the end. Anyway, Linda, thank you so much for your kind and amusing comments. I'm really privileged to be able to participate in this summit. I think it's a critical time for people to really understand sort of where we're going with DIS. And I was actually, excited to see so many young people. Because the good news is when you have young people, they don't suffer from founder syndrome. In the field of STDs has suffered from founder syndromes too long, and it's time to change. So I've been asked today to talk about the changing roles of DIS from a national perspective, and I'll take the next slide, Greg. So I want to, for those of you, it is important to learn from history. We don't want to repeat history, so I'm going to give a little bit of history of DIS intervention services. And encourage you to read some important landmark documents from the then called the Institute of Medicine. It's now called the NASM, the National Academy of Science, Engineering, and Medicine. I'm going to talk a little bit about, how I see where we're going with DIS. I actually found some old slides that I've pulled out for some reflections I had in 2012. We haven't made a lot of progress. And then I also want to talk a lot about what we're doing with finally professionalizing and working towards certification for DIS. So next slide. So for those of you who have not studied the history of public health, I think it is important to look at this Institute of Medicine document from 1988 that was revisited in 2002 and really summarize is what's the government's public health role? How do we differentiate ourselves from population health and the healthcare system? And our responsibility is assuring conditions in which people can be healthy. And in the field of STDs, we want people to make the easiest choice, the healthiest choice. And we're still challenged by some of our choices we give our clients. But we do this through assessment, assurance, and policy development. And I think it's important to have frameworks and roadmaps when you're designing your programs. We know, at least in the field of STD, we don't have enough money to do everything we would like. So we can't just rely on purchasing things to be successful. We really have to build leaders and influencers to be effective in the field of STD. We have to work with our stakeholders, our communities, and our partners to help them leverage their resources to help us achieve our goals. Next slide. And these core functions of public health have been turned into this assessment, policy, and assurance, have been turned into sort of 10 core functions and essential services of public health. These include monitoring health, diagnosing and investigating, informing educating and empowering, mobilizing community partnerships, developing policies, enforcing laws, linked to and providing care, and assuring a competence workforce. So where does the DIS worker fit into this wheel of essential services? Next slide. So for a long time, we were kind of generalists and we really didn't have an identity. So it's now time to really define what disease intervention is. And this is a busy slide, but I think it's important, if hopefully the slides will be available, for you to take time and reflect on these activities under these essential functions. So clearly, in terms of investigating health problems in the community, DIS does case investigations, contact tracing, outbreak response, ground level community engagement, collection of surveillance, epidemiologic, and community assessment data. Certainly the field is changing in terms of its linking people to services. That's something certainly HIV worked on for many years before the STD field realized how important it is to recognize that with co-occurring conditions, you're not going to be successful in preventing STDs or repeat STDs if people do not have other important social determinants of health addressed. And so we want our DIS to be thinking holistically about their clients, no longer thinking, well, I just got to find that syphilis contact and cha-ching. I've heard this in the past, I'm going to interrupt disease transmission in the community. We've got to make sure that people get comprehensive STD prevention, don't miss opportunities for screening for other STDs, expedited partner therapy, vaccinations, condoms. We need to make sure that, STDs are having an impact on HIV. For many years, there were some studies in Africa that suggested not, so HIV prevention was not really embracing STD prevention as a HIV prevention strategy. But we now know that STDs are good biomarkers in some populations for HIV acquisition. And we need to make sure we're testing our populations not only with HIV tests, but we also need to be doing viral load testing, because many people who come to STD clinics don't have access to care. They don't access HIV prevention services. They don't have a medical home. And you'll find that they may say, yes, I'm living with HIV, but when you get your viral load, you'll find out that they are not as suppressed as the community level suppression or as the level of suppression you'll find in a Ryan White program. And certainly many individuals are eligible for PrEP and PEP. So these are things that we need to be working on to help support ending the HIV epidemic. And then the areas where we really need to help to link to safety net services, in addition to having a medical home, we need to be addressing behavioral health issues, intimate partner violence, substance use disorders, family planning, prenatal care. Sometimes when I talk to DIS, they seem overwhelmed by all these things. It's not saying you become an expert. You just need to know where these services are in your community and link. We also want to make sure that we're providing counseling, health education, and something I'll talk a little bit more about, I like to call public health detailing, because it's really important that we engage providers in the work that we do. And good DIS have a lot of knowledge and information that really can help clinicians do their job better. And there's something called academic detailing that the drug companies do. We need to be doing more public health detailing so people know what our expertise is and what we have to offer. Then we need to mobilize communities, and we can't do any of this without a competent workforce. Next slide. So, okay, so let me talk a little bit about the history. So Greg, we're gonna go a little fast here so I can have time for questions. About the history of the workforce and the changing public health environment. So I actually, next slide, was at a meeting with ASTO, and it was a meeting in December of 2012 about the integration of public health in primary care, and was sort of asked, what should the landscape of STD prevention look like in 2013 and beyond? So I'll give you my answers. Next slide. So I felt, because that was at the time of the Affordable Care Act, where there were a lot of people saying, we don't need public health. We don't need STD clinics. We don't need TB clinics. Everyone's going to have healthcare access, and everyone's going to get taken care of by their primary care provider. And they're including some people in San Francisco that thought that. And I said, this is interesting, because we've known in TB and STD that if there's not focused expertise and opportunities for focused access, there can be some challenges. But I guess, is this my computer doing this? Telling me things I need to do. So first of all, we do though have to recognize most STDs are asymptomatic. People don't know they're infected. So we need to take advantage of getting them screened and treated at point of access. And for many people, that is the primary care setting. And that includes HIV care and family planning. So we need to take advantage that the healthcare system is really delivering a lot of STD prevention services through timely screening and timely treatment. So that's a change, and we need to work with them so that they can do the best job possible for the patients that they serve. Where we have not done very well, we're doers in the field of STD. And we tend to, do and find contacts, but we don't stop and assess what we're doing. We don't evaluate what we're doing. We don't think, what are the system policy changes that we should be doing? So we need more investment in assessment, insurance, and policy so that we can scale up the prevention services that need to be provided by the healthcare system. And California has been a great example of being the first state that legislated expedited partner therapy as something that could be done without a good faith examination by a provider. Certainly our HEDIS measures and our U.S. Preventive Services Task Force have come up with screening recommendations that generally patients should get without any copay. So we have opportunities of system level change. But we also need to recognize that our healthcare system is not enough for everyone, and we still need to provide those STD prevention safety net services. And as I mentioned, we've got to foster public-private partnerships. We've got to have better impact measures of what, I have now with CDC, I've got to testify to Congress and say, what I'm doing with the money they give me and what the impact is. And to be honest with you, I'm limited with the data that I get from some of our STD programs. And then we really need to rebuild our workforce capacity. For those of you who haven't been around, I was in California in the 2008, 2009. We had to lay staff off. The economic downturn was stark. And everybody had massive cuts, and we have not rebuilt since then. And I think the challenges that we're having with COVID right now has exposed sort of the erosion of the public health workforce, including STD clinics, including DIS, and safety net services that's making it difficult for us to respond to COVID that all of you, I'm sure, are well aware of. We're a little bit still working on some of the issues at CDC. Next slide. So I also thought about, well, what are we going to have our DIS do? Because at the time I came into the field at City Clinic and the STD program in '87, DIS were embedded in the STD clinic. Most STD patients were seen in the STD clinic. And we basically had an STD clinic and contact tracing programs. Now, when HIV came along, contact tracing was considered a little stigmatizing, so we changed the word to disease intervention services or partner services. But we really didn't have a very diverse workforce, and we were not doing much with community engagement. And so I think that even in 2012, I thought that we needed to start, expanding our skill set, doing more efficient and innovative partner services that met the needs of the community. Certainly, we were not doing a lot of counseling. And then there's a lot of syndemics going on where populations, everybody's knocking on the same door. So why are we having separate, HIV and STD DIS teams? Why are we not linking with viral hepatitis? So if we're really going to provide integrated services at the client level, we need to start working together and making sure that happens. It's fine if programs want to work together and be separate. I've seen very different structural, approaches to STD and HIV in the country. Some can have a merged program, but then the leadership at the top just has sort of a separate STD manager and really doesn't give a lot of attention to STDs. And I've seen some programs where the STD program and the HIV program are separate, but they work together famously and achieve that goal of client integration at the client level and at the service level. And then at that time, I also thought there needed to be more linkage to care, more analytic and quality assurance activities, and more involvement in surveillance. Now, DIS are not trained as epidemiologists to do surveillance, but they are people who are out there in communities who can collect important data to educate our epidemiologists about what's happening. The distinction I make between DIS and epidemiologists, and I'm sure George will appreciate my comment, is epidemiologists say they do case investigation. What they consider case investigation is going out and collecting data, getting data out of someone and writing up an MMWR. DIS understand that there are people behind the data, and they go out and they have to engage, and they have to use all their sort of intangible human skills to build that relationship, to build the trust, to build the rapport, to be able to intervene and achieve the goals that we're trying to achieve. So for STDs and HIV, that's testing, that's treatment. Now with COVID, we don't have a lot of tools in our toolkit. We're left with quarantine and isolation. Hopefully we'll be moving to vaccine at some point. But it's important to recognize the difference when we start talking about case investigation, because those terms are, at least at CDC, are used by different people and have different definitions, and we've had trouble communicating what contact tracing is, because we have people that think contact tracing is just having contact tracers. But if you just have contact tracers without a good case investigator, we might as well all go home, because there won't be any contacts to trace. And epidemiologists use the term case investigation in a very different way. Next slide. So I'd like to talk a little bit about the DIS certification project. It sort of struck me when I was in California, and I've been working on it for my whole career, and you know, I need some people to take it on. So basically the challenge about DIS work is that there is no school you go to and get a degree in DIS. I can hire a doctor tomorrow, a nurse tomorrow, an epidemiologist tomorrow. I cannot hire an a DIS tomorrow. They have to be trained, they need knowledge-based training, they need skill-based training, and they need, at least back in the day when I was working with DIS and I went out in the field with them a lot, you need about 12 months of on-the-job experience to become a high-quality DIS investigator. I call DIS like the FBI of public health. Maybe some people will find that a little insulting, but you're like the boots on the ground, you know, Peace Corps of public health, FBI of public health. And this is the challenge we're having with COVID. All of a sudden people thought we could hire people in a month and do all this contact tracing. And they didn't understand that this is an investment in an on-the-job training that the public health field has done for years. And we felt that, one, it's time to have a certification so that we professionalize the workforce, so that there's a standard job description across the country. I can tell you every county in this country has a different name or job description for a DIS. And because of that, there's no standardization. There's wide inequity in salaries. I will say those who work in San Francisco do pretty well. But it's a challenge when you're asking people to do the same job for not the same pay. So we're working hard at the national level to implement this certification program. So let me talk a little bit about the project, the process that we have gone through. Next slide. So first of all, you know, why do we want to have certification? And basically, I want to recognize or educate you, because I've learned a lot by going through this process, that certification is a voluntary process by which an organization grants a time-limited recognition to an individual or unit after verifying that he or she has met standard criteria. So this is not licensure. This is certification like health educators get, CHESS, certification. There's some nursing certification you get. So again, the goal is to formalize the role of DIS. And DIS, we're equal opportunity. The skills you need to do STD, HIV, TB, or COVID are all the same. You just have to have a little different background about the biology, the diseases you're working with, the tests that are available, and the interventions. So I truly believe that a good public health department invests in their DIS, because those are the people that are going to respond to any, emerging threat, public health requirement. And the other thing that we're trying to do with certification is, if you don't know, community health outreach workers get reimbursed by Medicaid. We don't have a business model, and we really need, if we can have a standardization, we can have a business model, we can educate our healthcare system that DIS are important, and they're going to save you money in healthcare costs. So we need to have a sustainable approach to DIS and make sure that we can bill for their services like some other outreach workers are able to do. Next slide. And basically the purpose of the certification was to sort of standardize, validate knowledge, skills, and abilities in the area of communication, counseling, case management, disease and outbreak investigation, linkage to care and retention and care, and provider and community engagement. We wanted to make sure there was standardization and improvement through the training that people will have to go to be certified, that there's quality and consistency of service delivery. We recognize, though, the first thing I learned about my job when I came to San Francisco, a state epidemiologist in New Mexico said to me, I don't know, Gail, why you want to work at CDC? All the action's at the local level. You can't even get invited into a state without an invitation from the state. You know, you feds, you just can't come in here. And that's the reason why I decided to work at the local level, and it was really true. So it's really important that this workforce is recognized and that we have more of you. So next slide. So we, the other thing that I won't go into detail here for the sake of time is that, you know, people think certification is not just a piece of paper. Well, it's not. It's very complicated. There are complex industry standards, legal implications, and it's a major undertaking. So we've gotten through a lot of this process. We still are trying to focus on how we can implement is where we are challenged right now in our process. So next slide. And I just want to acknowledge that we had a lot of input into the work that we've done when I go through the process, ranging from the Public Health Accreditation Board, which is the board that accredited health departments. We contracted with them and they led the process. We had our other divisions at CDC involved. We had lots of subject matter experts, and we appreciate if some of you were involved in giving input to the process. We had a steering committee that was advising. We involved ASTO, NACCHO, NCSD, the TB Controllers Association, and some other contractors, and had our nurses advising us on how they do their credentialing. So the next slide will show you the process that we have been marching through. So first of all, we had to determine, was it feasible to do DIS certification? Because if you don't have enough people in the field, no one's going to want to pay for this process, because on average it costs about $500,000 to maintain on a yearly basis. And so that was the first question. The second foundational activities that we needed to get a handle on are job task analysis, which I'll describe sort of how many DIS at the time, this was in 2016, did we actually have out in the field? You know, how are we going to maintain a DIS registry, which has been a challenge? How are we going to help insert the DIS certification within the health department accreditation? There is interest at CDC to have health departments that are accredited. If they also have DIS are accredited, they will get bonus points in their assessments. And then we had to figure out what kind of model do we want to use, a test model, a portfolio model, or a unit, and I'll go through that. And then we really wanted to start implementation. And the first thing that we focused on is we need to find a contractor that we can administer this certification program, and we're still working on that. We thought we had found someone through COVID, and unfortunately, we just heard that a donor with the CDC Foundation right now is not prioritizing DIS certification, but we are going to make this happen. Then we recognize that we've got to modernize our DIS training and our DIS training centers. And then we wanted to look at sort of long-term sustainability, because as we all know, you know, there's very few professional organizations that are completely funded with public health dollars. Most of these are covered by academic institutions or other means. And so we want to see if there's a way we can maintain sustainability through schools of public health. Next slide. So first, I just want to outline the job task analysis, because this is important if you want to know what the future of DIS and what we expect DIS to do. So we had to clarify what the DIS job role is and establish the necessary and important requirements that would ensure DIS have the requisite knowledge that's needed for quality of practice. And these results from the job task analysis would inform training and other planning. So next slide. So the job task analysis, we did a survey and had almost 500 respondents around the state level HIV, STD, and TB directors. And it was very interesting. We had come up with a list of tasks and knowledge that we thought sufficiently covered the necessary content for a test for certification. And actually the survey response actually found a very high correlation with the task statements that were drafted by the job task analysis task force, where the concordance was 56 out of 57. And then the knowledge statements drafted by the task force were also rated high by the sample of practitioners And again, so we had, 99%, I don't know of any kind of study I've ever been involved in that I've got these kind of results. So we actually were right on the mark to what people in the field were thinking were the needed skills and knowledge sets that DIS need to have. Next slide. So the buckets that we came up with is that if a DIS who wants to sit for certification needs to be able to plan and prepare for case and field work, including data care. They need to know how to do investigative activities. They need to know how to, do cold calls to clients and how to engage them and interview them for the purposes of case investigation and contact elicitation. They need to have an understanding of surveillance so that they can support surveillance activities. They need to be able to analyze their cases so that they're targeting the right people and being having the highest impact. We also need to make sure that they understand the clinical support system and the client linkage services. We also recognized before COVID, we have lots of opportunities for testing and treatment in the field by DIS. When I was in San Francisco, I allowed my DIS, I was the provider that ordered all the medication. It was under my medical license, and I allowed them to go in the field and do testing and offer treatment to cases that weren't coming back for treatment in the clinic. They need to understand outbreak response and emergency preparedness and where they fit in the role when we're having pandemics like the one we're having now. And they've also got to have an understanding of the healthcare system and clinical quality improvement, including this public health detailing. So I think DIS work is a really challenging field. I think there's lots of opportunity. Some of my best DIS have stuck with it and are now supervising and developing the next generation and are managers and are doing really important work. There is a career path for DIS. And some people also do this early in their career and realize I'm learning really good skills for any job that I want to move into. And I've had DIS move into policy positions at CDC, communication positions at CDC, management positions at CDC, either program management or administrative management. I have one DIS that was with me, Linda probably remembers him, who's now a filmmaker. I just think it gives you life skills like what you get going into the Peace Corps or other things, that you will be a hot commodity if you have all these skills and knowledge for a really interesting career path. Next slide. This slide's probably a little bit too detailed. And I know I want to leave time for questions, and I know I talk fast. I have never been able to slow down because there's just so much work to be done in the field of STDs. But I wanted to give you some examples of things that we really should be having DIS doing. And, we got to get rid of the paper-based stuff. That's got to go. But just in terms of planning and preparation for case and field work, you guys are younger, you know all this, but, I think some other people haven't. We need to be using the web, doing research on the web to figure out what you can learn before you make that cold call so that you have some basis of foundation of information. And again, we keep everything confidential. We are not, and we will fire people in the field of STD if you breach confidentiality. You got to figure out how to navigate these electronic medical records. And a lot of times really important information is hidden in some section you don't even know how to get to. And then we also need to be navigating, communicable disease surveillance systems and checking out what we know from measles cases and other cases that we can use to prepare for any case or field work. Then people need to be ready for the investigation activities, and you've got to have, situational awareness, community safety. And this is the area where we've got to start realizing that field investigation right now, with the level of our workforce, it's great in San Francisco when you're dealing with a city 7 by 7 miles, but when you're in Fresno and you got to cover the whole valley, it makes no sense to get in your car and drive all day to find one person, only to find that their partner is not home. And you got to go back to the office because the office won't let you stay overnight anywhere. And so that's just not, the field investigation is not as cost effective as it used to be when we had a much larger workforce. And we've really got into to get into the technology assisted investigation And I know I still hear it from some of our old timers that the only way to do good DIS work is you got to go to the field, you got to look the person in the eye and trust them. Well, I'm sorry. You know, if you can talk on the phone and work with technology, we're finding that sometimes people are disclosing more information without someone looking in the eye. And so there is clear science saying that phone calls are just as effective as field investigation in engaging people and getting them in for testing and treatment. In the client encounters and interviewing, obviously establishing a confidential setting and confidentiality's got to be at the forefront of everything that we do. We need to have people who've got cultural humility, who know how to do motivational interviewing, know harm reduction strategies, and how to successfully engage vulnerable populations. We're talking people with substance use, we're talking people with unstable housing. If we don't deal with those issues, we're not going to make any impact on our rising STI tides. We've really got to deal with the context of people's lives these days. Obviously, we need to help our surveillance epidemiologists to collect additional information, because sometimes people will disclose to the DIS information that they don't disclose to a quick epidemiologist. But the field of STD for a long time relied a little bit too much on self-report data. And we also need to do a little bit more of reviewing medical records and getting the appropriate clinical information we need so that we have the whole package. We've got the information from the patient that's not recorded in the medical record, and we've got the documented information from the chart abstraction. Then when we get to our case analysis, I'm sorry to say, but the visual case analysis for syphilis is a very nice exercise, but it's numerator data. It's not helping us understand sexual and social networks. Not everyone transmits equally. And we've really got to target our interventions to networks, not to everybody that gets reported to the health department. We know from COVID, there's a lot of cases that don't need follow-up. They might be a professor that got infected in the hospital. They know who their partners are. They know what to do. We know some contacts, by the time we find them, they're already past the quarantine station. So we've really got to evaluate and target where are we going to have the highest impact, and look at our cases in more of a network way than in sort of a case numerator way that we've done in the past. And I know a lot of times that my staff in San Francisco and in the state were very unhappy with me because I did want to collect data. DIS have a wealth of information in their head, but it's not doing us any good if we can't get it down and have a better understanding of risk factors and venue identification so we can inform our target intervention. So there's a lot of analytic work that the DIS can do, and I really wish we had more DIS, summarizing their best practices. I know there's really good work going on locally, and we need those success stories desperately at CDC to educate Congress why we are doing great work and need more DIS. The other thing that we should be looking at is missed opportunities or gaps. And we've got great examples with congenital syphilis, which I know is a big problem in California. And that we need to, figure out where are the leverage points that we can do system level changes. And educate providers or change systems so that we can make sure that women are getting the screening and treatment that they deserve. I realize we've got a big problem with women that have no access to prenatal care, and that's where we've got to put on our innovative hats and don't think we can answer these questions. We need to work with our maternal and child health programs. We need to work with the case managers that are funded by maternal and child health, and don't feel that we have to do this alone. And then we also have a lot of missed opportunities with PrEP in syphilis and gonorrhea cases that are not living with HIV. So that's a lot of analytical. So if you like analytical stuff, we've got lots to do in the DIS world. We don't want you just sitting at your computer. We want to value the work you do with people, but there is things that we need analyzed. Next slide. So, and these are the examples of things that we're going to be training on and expecting you to be able to do to be a high quality DIS. Now, obviously for clinical support and linkage services, client navigation techniques, linking people to PrEP, linking people to care, re-engagement in care. Obviously there's a lot of case management and interesting ways that TB does their work that we need to learn from. And then obviously, in my opinion, DIS should have the ability to, bring testing to the field, should be able to draw blood. I know California has a law that passed while I was here that was very unfortunate. It was designed for blood drawing stations because of a person with mental health issues was reusing needles. Unfortunately, DIS have been subject to that training law. You can you get more training on how to do a figure stick than most diabetics do. We've got to work on that legislatively. But DIS should be able to do venipuncture and collect specimens in the field. And I also think that they should be able to do offsite, PPDs, although we're moving to more blood-based testings for TB and HIV and syphilis. And then, DIS need to recognize that outbreak response and emergency preparedness, they're part of the team. And I know that a lot of times the preparedness people who sit in a different office, they don't even know who DIS are, and this is really true around the country. And they need to realize that they're not going to be successful without having the foot soldiers on the ground doing the community work that needs to be done in any outbreak. So all DIS need to be trained in incident command, system training, have basic introduction to public health preparedness and emergency response. We've got a lot of training on CDC's university that all of you can have access to. I know California's doing a lot of this. And then you should be involved in tabletop training exercises and practice drills. One of the reasons why we're not prepared, at least at the national level at CDC, I've been there for 10 years. I've not been to one tabletop exercise. So we are not, we kind of react when something happens. That is not preparedness. And then we also have new technologies with molecular data, and it was started with TB and now HIV does, that we really need to understand how to use molecular data in addition to our epi surveillance clinical DIS data to really be able to identify and prioritize our outbreak response activities. And then lastly, for those who are interested in healthcare, we need to have a better understanding of our healthcare systems and how we can work with them and leverage them and help them improve the quality of the activities that they're doing in the field of STD prevention so the patients get the services they deserve. Next slide. Okay, the other thing that we identified and through the job task analysis is there are critical soft skills that are essential to be successful as a DIS. And we know that not all of us are up to speed as we should be in our soft skills. So I guess I could work on active listening, but we need ethical and professional conduct. Remember, what you say to someone who you think in a quiet room in your office may be overheard by somebody else. Never say anything in the field of public health. I'll say this, and I get up every morning and remind myself that you don't want on the front page of the Washington Post. You never know who's listening. It's the same for patients in the hospital. I always had rounds in the patient room. I never talked outside the door. You need to be an active listener. You need to have open communication. You need to be a good communicator. You need to be a good writer. We need good writers these days. You need to be a critical thinker. Have those antennas up. You're going to identify the outbreaks because it's always an astute laboratory clinician or DIS who identifies outbreaks. It's not our surveillance system. I can tell you that I've been working in it for 40 years. They tell us about trends. We're too late in our surveillance system to identify outbreaks. So it's that when you have that, something's not right here. Don't forget that. You need good negotiating skills. You need to be able to do conflict management and resolution. You need cultural humility and emotional intelligence, especially of all the things that Linda said that we're dealing with in our society today. And you need to be flexible and adaptable. I say if you're in the field of STD, you're building the airplane as you're flying it. And if you don't like sort of coming into work and don't know what's going to be happening that day, go work in a bank. STDs is not the field for you. And then obviously we've got to maintain confidentiality at all levels so that we can have community trust and client trust in the work that we do. So these are some trainings that we want to be working on with our training centers to make sure that we have these foundational skills. And certainly I would say some clinicians could use these skills as well as some epidemiologists, but we're talking about the DIS workforce right now. Next slide. Just to let you know, the numeration in 2016, we've been having trouble enumerating since then. We've been working with NCSD. We're going to be working with NACCHO to try to figure out how big is our workforce. We basically found out in 2016 there were only 2,211 STD, HIV, TB non-licensed DIS. There was about 1,600 in the STD arena and 550 in TB. We did not include nurses. We did not include community health outreach workers, epidemiologists, public health nurses, and federal assignees. This is not saying that they can't be DIS. They just have to go through the training. There's some really good community health outreach workers that actually, get jobs as DIS. There are epidemiologists that have all the attributes of those human skills that can be good DIS. So it's really the training that people need to be able to be a high quality DIS, regardless of their employment category or funding category. Now, we've obviously been trying to figure out how many DIS we need for COVID. Dr. Frieden came out with this army of 100,000 contact tracers where we're finding there aren't that many contacts per case. So just to let you know how we do things at CDC, we do simple math, and based on what we know, we kind of said how things are working right now. We're going to have 1 case investigator for 1 contact tracer, and then we want 5 case investigators supervised by a DIS. So we're just coming up with numbers as to the workforce that we need in this country to at least deal with COVID. And then when COVID goes away, we want them all to go back to STD, HIV, TB work. They'll sharpen their tools while there isn't any emerging threat. And then when the next emerging threat comes or the second wave of COVID comes, we will be ready. Next slide. The model that we ended up, we basically looked at 3 models. We looked at the potential to address the intended outcomes we wanted of certification. We looked at costs, and we looked at validity and reliability. And basically there was a test model where a DIS takes a test. There was a portfolio model where you had to kind of like an artist, bring your portfolio of work in your pouch and your DIS investigation to someone who would review it. So that was still an individual certification. And then there was a unit-based model where a unit would be certified within a DIS health department. So what we ended up deciding on, next slide, is that we felt that the test-based certification model was better because individuals could take that with them to other jobs in other states. We also thought a unit could penalize some good people that had some weak links on their team. And we just thought the portfolio was too much work for everybody. So we basically are working towards a test-based certification. We want the accreditation to be part of health department accreditation. We have buy-in at CDC for this. We need to get this accreditation organization. And we are going to let health departments do unit-based models. It's just performance measurement if they want to do that. And then we need to deal with the training gaps, and we need to sustain the program. Next slide. One of the interesting things that we did was we actually mapped the job task analysis to public health criteria in bachelor's schools of public health. This was not schools of public health, master level, this was bachelor's. And it was interesting that about 90% of the knowledge work actually aligned with a lot of what kids are getting in I shouldn't say kids, excuse me, young adults are getting in universities and college these days with a public health major. But we did find that only 55% of the job tasks and only 40% of the knowledge competencies were found in these programs. And it was also recognized that about 9 knowledge competencies are really unique and really require on-the-job training. So you would need to be, if we are going to have training going on in undergraduate programs or in schools of public health, there's going to need to be practicums, during the summer so that you're getting this on-the-job training so that when you graduate, you can then just go get a job in a health department, not have to get the job and get trained. And then 2 years later, you're sort of wondering, where's my career going? This has actually been written up in public health reports about the disease intervention specialist education for the future. And I encourage you all to read that because it's kind of an unknown article to many. But in that article, they state that an accredited public health academic program grounded in continuing education of public health competencies could address multiple components of DIS education preparation. Next slide. All right, so I just want to make a few reflections on the training centers because if we're going to modernize DIS, we got to modernize our training centers. Next slide. And so with our new announcement, we are asking our training centers to provide more training than just Passport for Partner Services. We want to de-emphasize old, less efficient models, and we want new innovative models that deal with the human skills as well as social media, network analysis, client-initiated partner services. Sometimes we assume our clients don't want to do anything. I think we're projecting our own, concerns on our clients. And we also have opportunities with echo models and telehealth like never before. And then, as I said before, we really need to figure out the payer structure for DIS so that we can have more ways that we can increase and generate the next generation of DIS workforce and leaders. Next slide. And the training centers are really being asked to just update Passport, but we want it modernized. We want new courses in outbreak investigation, linkage to care, public health detailing, use of surveillance and public health data, including the molecular surveillance, partner services, and linkage to care activities. We also want to develop a mentoring structure. You know, it's a lot like what medical students get is, you know, they go into their internships and their residencies, and it's really 3 years before they become a doctor on their own if they get trained in clinical medicine. And we don't really have this in place, that we really would like to have new DIS have a mentor. We're trying to get our staff at CDC to be available. We'd like to have some of our senior DIS in the state. They're really, you know, unfortunately too busy with, you know, state work, but we'd like to be able to find a financial structure. So if you're a really seasoned DIS, you know, you have 20% of your time paid by this special fund, and you know, 1 day a week work on mentoring other DIS in your state and maybe even in your region. And then obviously, you know, we've got to, you know, make sure that we maintain a plan that ensures training staff has, you know, basically, is a good experience. So that's what we're asking our training centers to do. I know we just got funded. They just got money from COVID. When you got COVID money, you're under the microscope of our administration, but I'm hoping that we can use COVID as a way to start getting DIS certified. And we're actually planning on using the PHAPs that CDC hires and have them maybe be, if we can get them trained this year, we'll see how the training centers are doing, that maybe they may be able to sit for kind of a pilot examination and have them be our first cohort of people certified for DIS. For all you youngins out there, we'll take more volunteers if you want to work with us at CDC on piloting our, our trainings. All right, next slide. So just to talk a little bit about the future, and then I really see great questions popping up, and I'm multitasking by reading and speaking at the same time. So I want to have a good time for question and answers. So I think
Gail, this is Alice, and you're doing just fine on time, and we're monitoring questions. So this is great. Thanks.
Okay. All right. So let's talk a little bit about the future. So let's get the next slide, and I appreciate Greg doing this. So again, in summary, you know, I think that I have always said I learned everything when I came to San Francisco. I was a doc that I've said many times. I was looking for a job to get back into public health. I'd been doing research at Stanford at the bench. I didn't really feel I was smart enough to work with organisms. I said, I got to get back with people. And the only job that was available at the time, and I just had my first kid, was the director of STDs in San Francisco. This was '87, the height of the AIDS epidemic, the highest rates of syphilis in the country. I had trained with Merle Sandy in Virginia, so he wanted me to be an AIDS doctor, and I didn't want to work at the General and be an AIDS doctor. But I'll tell you, what I learned from DIS was just amazing. And I always say, if I'm on a sinking ship, the first person I'm asking to be on my team is a highly qualified DIS worker. So we really need to, you know, expand the scope and skills beyond just STD contact tracing field investigation. You know, I've kind of given you the list of things we need to do. We need to make sure that at least, you know, all staff are cross-trained in, or not all, but that we've got staff, you know, cross-trained in HIV basics. I think, you know, there may be some basic training we do for everyone. It's kind of like you do medicine first and then you subspecialize. And I know when I was in California, we actually cross-trained all our DIS. I don't know if some of you remember this, to do TB work, because TB got to such a low level that it really didn't justify having a regional office of TB DIS and regional offices of STD. And I said, okay, yeah, I said to James Watt, give me a couple FTEs and we'll train our staff in TB and take care of it. But what I didn't recognize was the cost of the medical assessments that have to be done every year with TB. And so we actually did a lot of assessments in mass fitting, and then staff never went out on a TB case investigation. So it wasn't worth the money. So we realized that we needed a smaller core group of people trained in TB, not everybody cross-trained in HIV, STD, and TB. And I think I'm also hearing from DHAP at CDC is they probably want some specially trained DIS that do the HIV molecular analysis with their epidemiology, because that's also very specialized, detailed kind of data work that they need for their medical epi, network analysis, although I try to educate them that TB has DIS do this work, and it's not that specialized, but we all need to learn from each other. And then obviously I can't say it enough, we've got to be, have our, these human skills are so critical, and they're so critical for us to be able to, have relationships with our clients, with providers, and even our colleagues that we need to collaborate with, community health outreach workers, patient navigators, and bridge workers. Everybody has a role to play here. DIS shouldn't feel competitive with any other public health worker, be it an epidemiologist or a bridge worker. I think the unique skill set that DIS has is sort of that ability to go into communities and find vulnerable populations that are not, for whatever reason, connected to our systems, and really helping link them in for the appropriate interventions, be it testing, treatment, or vaccination. Obviously, it takes time to support surveillance and outbreak response and collect data and do program evaluation. But I bet you if everybody critically looked at everything they're doing today, I'm not sure everything we're doing is of high impact. We kind of keep doing and we don't take the time to pause. And I think with our level of resources, it's really critical to invest in evaluation and using data for public health action, and recognizing that, something worked well for a couple of years or 10 years, but, the world has changed, and we need to start when you're in different phases of your epidemic. And I will say San Francisco's in a very different phase of their HIV epidemic than when I was around. And it's quite a success story. But now you're dealing with very vulnerable populations, and how you reach them is very different when you're dealing with unstable housing and with substance use than when we were dealing with large communities of gay, bisexual, and other men having sex with men who didn't have information, didn't have access to care. A lot of those problems have been solved. So it's really important to make sure we're collecting the data so that we can be, educating our decision makers and stakeholders in our communities of what we know and what we don't know, and where we need to move forward. And then the other thing, and we're working on this at CDC. When I come to CDC, I had a long list of things that I'd complained about in the field, and I felt, oops, I guess now I'm here, I better get it done. We have got to stop using stigmatizing language. I don't want to hear the term suspect, associate, recidivism. There's a language that the DIS use. And to be honest with you, my staff at CDC have told me, but Gail, that's how we talk to each other. I said, well, I'm sorry, but you're never going to integrate into the healthcare community, which you need to do to survive. You're going to be a dinosaur talking that way. So we've got to stop it. And we're coming up with a glossary that's going to translate all what I call the DIS jargon into normal language. So we're part of the public health system. We're part of the healthcare system. And I think it also will help us with stigma and discrimination, which a lot of people think stigma and discrimination is all with HIV. There are many people that I took care of at City Clinic who suffer in silence and don't have a voice, and we don't have an advocacy group that speaks out like HIV does. So it's really important that we establish that engagement and that trust, and that can start with the words that we use. And then obviously we need to be working towards certification. So my last couple of slides show that, we sometimes, I think in this day and age, people wonder, what do we do at CDC? It must be a terrible place to work. We don't hear from you. It is hard. I mean, I encourage everybody, and I say this at CDC, take part of your time of your career, work at the local level. That will be the most invaluable thing that you can do. We have people at CDC who are trying to do contact tracing, and they're trying to do health department response, who have never left Atlanta. They have no understanding how state and local health departments work. And I thought I was unqualified. I was definitely unqualified when I came to San Francisco, because as I didn't finish my sentence, I had never seen a case of syphilis. I'd never taken care of a transgender patient. I had no publications in the field of STD. My work in public health had been in respiratory and special pathogens, but the guy hiring was a little cuckoo. And so decided to take me over I said, I want a public health doctor, not a rat doctor. So I got the job, and I figured, okay, I'm all in. But I think that it's really important to have that local experience and that contact with clients, because we can only be better if we know what's happening in our communities and with our clients. And the farther you move away, especially at CDC, sometimes I have to remember my patients I saw at City Clinic sometimes when I get up, because I feel like, am I doing anything that's worthwhile here sitting in Atlanta? Sometimes I don't feel like it is. But again, as I said, we've got to get into technology changes. Obviously, the way people meet partners now is very different with our geosocial networking apps and our sexual networks. So we've got to, go where the action is, not expect people to come to us. I've mentioned the need for holistic patient and client care, surveillance and outbreak. And again, we've got to use the internet. We got to figure out how we can do more home testing, more field testing, and public health detailing. And then the next slide shows something that we've been working on for a while, and we certainly thank Frank Strona, who's in California, who's been taking the lead on technology-based partner services. So if you haven't seen what's on our website, because a lot of times we don't advertise what's on our website and it's buried and hard to find. Oh, shoot. I got a link here. It didn't get on my slide. We'll have to get that link out to you because clicking here is not going to help anybody because we're on a PowerPoint. But first of all, we now have a toolkit that serves as a general resource for health department, community-based organizations, and others on how to use the internet and other technologies to trace and contact persons potentially exposed to STD or HIV. And certainly these tools can be used for other infectious diseases. There's also an app simulator that's a quick exercises designed to familiarize staff with the basics of mobile apps and how they can be used for DIS partner services, kind of like the tutorial we got at the beginning of the Zoom lesson. There's also a listserv if you're really interested in peer-to-peer learning. There's quarterly peer-to-peer support, discussion, information sharing. And then we also have been using Basecamp. We've been getting some positive feedback, and there's discussion boards. We use this to get feedback from our grantees. And it's a way that not only do we get information about what's the most important things the field is struggling with right now, but we also get people to share peer-to-peer. So people will share examples of protocols. It doesn't have to be cleared by CDC. Just people just share scripts or policies of how you use digital media. So I encourage you to take a look at that. And then if you don't know, next slide, our training centers for, oh, thank you, Stacy, for getting the link out to everyone. So we just recompeted our training centers. And I really felt strongly that we had to go for 4 because if we get more money and only had 2 like we had in the previous cycle, we still are, are not having the opportunity for diverse training centers. So I went for 4. I know the training centers were a little discouraged in the beginning because it wasn't much money, but COVID is certainly helping us. And you can kind of see where the training centers are located. We have the New York State Health Department and Health Research Incorporated in Albany, Healthcare Education and Training Incorporation, or Inc. in Indianapolis, the Denver Health and Hospital Authority in Colorado, and then obviously UCSF in San Francisco. And UCSF is also our coordinating center for online skill-based training. And we also have a contract with the National Coalition of STD Directors in ASTO for doing online knowledge-based curriculum. And certainly we want feedback on the COVID curriculum that's out there, and certainly want feedback on any curriculum that's out there, skill-based or knowledge-based, so that we can work with our training centers to make sure we're designing training that is meeting your needs and giving you the skills that we talked about today. So I thank you very much. I think that's my last slide, and I would love to hear from you. So I'm open to questions that I can answer as a federal employee.
Thank you so much, Gail. That was such an incredible presentation. And I think, as you mentioned earlier, there's so many newer staff in the field. So those of us who've been around for a year or 2 more have had the opportunity and benefit to work with you and learn from you, which has made us much, much better professionals in the work that we do. But we do have a few questions that I'll just start with. We have, I think, until about 10:30. So is that right, Linda and Eileen?
Yes.
So we've got 10 minutes?
Yeah.
So one question that came in that would be great if you could address, this is regarding certification. And the question is the certification going to make the DIS field more inaccessible to those who don't have access to the education and money to get certified? If we want DIS from the local community, which often coincides with more marginalized populations, then having a certification process might make them then unable to access it. So could you speak a little bit to how we see certification rolling out?
Yeah, so we first of all value diversity in our workforce, at least I do. And we recognize, at least I, feel like sometimes degrees don't necessarily reflect skills or wisdom or experience. So first of all, there's not going to be a requirement that you have to have a bachelor's degree to be certified. And the other thing is that the cost of the certification, we are trying to build into our program grants so that your workforce would pay for your certification. So that's the goal. We do not want to have people feel that because of income barriers that they can't be certified. We're hoping to keep it, low cost, and I don't want to use the word subsidized, but we're very conscious that for us to get the best, we can't have, just like healthcare, we can't have financial barriers. And so certainly we want to hear as we move forward with this, are there problems that people are having that we're not achieving our goals? Because as I said, when you're up at CDC level, you're sometimes disconnected. And so and I think also we've been trying to fundraise to have scholarships and other things. So that's how we're approaching that.
Okay, great, thanks. There were another comment or two that were of folks that were saying that they really love this work, but they feel like sometimes it can be a dead end. So I think certification can definitely help in that area.
Let me speak to that dead end problem, because I think there's staff that I have that feel like DIS is a GS7 work. They think it's like this low-level, entry-level position. That's what DIS means to them. And DIS doesn't mean that to me at all. It's like medical school. You don't say, oh, you're a first-year doctor. You're a doctor all your life, and you move up into the system, and there's so much opportunity. So we have a lot of staff in the field, and we don't have, because most of our money goes out through our grants, we don't have the resources to fund as many promotions in the field anymore, because we just don't have the resources. So we've created a career track that we've got a pyramid, which is always a good structure for your organizational structure. If you get too top heavy, you're broke and you don't have enough workers at the bottom. So we've got a structure where we want to bring in more PHAPs, and even in the federal government, we're going to be hiring more PMAPs as some of my GS-13s retire. And they'll work at the local level, and they'll become highly quality trained. Then they can move into a supervisory position and learn supervision. Supervision isn't for everybody. And then once you get to maybe 3 or 4 years into the job, it's really time for you to decide, where do I want to go in my public health career? Do I want to stay within, and I use Romney as an example, who stayed in DIS work all her life, and she's now working at the highest level at CDC. Sorry, California had to steal her, but she's got that expertise and sits at a table, with, the Trump administration because of her expertise and the questions she can answer. So, but there's, as I said before, there's avenues through communication and through policy job opportunities. There's program management, program coordination activities that a good DIS can move into. And so at CDC, we've targeted communication positions, policy positions, project officers, which I like to call prevention specialists that oversee grants, and then the admin route where you really like the admin part of government and work, and you can move into a Wendy Wolf position or a Jackie Minks position. And having that program background is invaluable. We now are getting accountants at CDC, and I'll talk about my DIS training center, and they'll say, well, which is that 1805, or they don't even know what the meaning is of the money we're spending. And to me, when you have money, you need to know how you're spending it and articulate what it costs to do things. So I think there's quite a lot of, and then some people jump ship and, go to graduate school or want to get more advanced degrees or go to medical school.
Yeah. Yeah.
And I think that, I see the PHAP program as kind of the feeder. And I'd like to have all states, when they're hiring new staff, have them be part, even if they're not in the PHAP program, that we mentor that models. Like I did EIS, I mentored that model in the fellowships I had for epidemiologists and docs in California.
Mm-hmm. And just for folks that may not be as familiar with that acronym, could you tell some of our newer staff what PHAP stands for?
Okay, so PHAP stands for, I got to get it right. It was basically, it used to be, that it was called the Public Health Advisor System. And there used to be 600 people that were hired every year. There's a cadre of people around that CDC hired, and they all started in STD. And if you look at a lot of people at CDC, a lot of them started in STD, and now some of them are, division directors, deputy center directors, and a variety of staff. So PHAP stands for Public Health Associate Program. It's a program that now has been merged with the Prevention Specialist Program that used to be 3 years and you had to have a master's. Now this program does require a bachelor's. And basically you apply sometime, and we can certainly get you the information out there, either after college or after a master's program. It's pretty competitive. They want people to be flexible. So if you say, I want to work in San Francisco, they may say, we have a job in Minneapolis, and if you don't want it, we're going to take the next person on the list. So you have to have that flexibility of not being so narrow, because I think they want people who are flexible and adaptable and are willing to move. And it's a 2-year program. We're assigned to a local health department, and I know that you've got people in California that have done the program and are now working in various positions in the state health department and locally. And we want more local programs to be putting good applications in. I know it takes time and resources, and we're trying to improve on that. So it's a really great opportunity. And the one real advantage, I'm just telling you how the federal government works. It's hard to get into the federal government low-level positions. We just have so many applicants. We have so many people that, have opportunities for federal employment. It's very hard to get in at like the GS 7 or 9 level. And Dr. Frieden did something so that PHAPs, when they graduate, have access to a federal job. They still have to apply and match. So it's a good opportunity as a way to an entry-level position to get into the federal system.
Great. And it looks like Greg posted a link to that. So that's wonderful. I think we may have time for like one more question, and it's related to some of the areas that you've been talking about, Gail.
Okay.
And this is because you've been alluding to this, but what are some skills or new staff or new tasks that DIS could use to enhance their work in the current climate? And I know that you kind of laid out a list of soft skills, which you addressed, but in addition to anything that you've just mentioned, is there anything, like if you could think of 1 or 2 things that would really enhance work of DIS in the current climate, what might you emphasize?
Well, I think the comment about resilience, life is, I've been through ups and downs in government. I've only worked in government my whole life. And, you have to weather the storm, and you have to have those antennas up to realize when you are not going to be the solution, but you will help someone else be the solution to the problem. Mm-hmm. You need to let other voices speak, but help them speak. You've got the data, you've got the science. So it's these intangibles that I say they're just human skills that are just so critical, of just being self-aware, yeah, and having that active listening, and just facilitating things to happen, and that community engagement. And then the other advice I kind of give people is, a lot of people at CDC, now that I'm the division director, like want to get my opinion on things, and like, what's the most important thing you think you need to do? And a lot of people at CDC think it's having your, publication list, be big. And the advice I give everybody that's helped me in my career is build relationships. That's the most important thing that you can do. You never know. It's like Linda. Hey, Linda, do we think we'd be talking now? You just never know who you're going to run into, who's going to be your next boss. And I actually just got a really nice note from Mitch Katz. And he said, Gail, I remember you breastfeeding your kid when I was interviewing for the job in San Francisco as the director of health. You guys don't know me. I used to bring my kids to work because, you got to work.
He was famous for that.
Now I got my grandkids. And he said, there's one thing that you told me, Gail, that I still to this day, I think about every day I get up. And you always said, Mitch, you got to remember, it takes both the organism and behavior to get into a public health problem of infectious diseases. Because if you have a lot of people having a lot of, sex where there's no protection, but the organisms aren't there, you're not going to get any STDs. Right. And with COVID, if you're not dealing with the behaviors, you're not going to solve this pandemic. And if
Yeah.
you're not dealing with the stigma and the trust in the community, I mean, I'll end with my 5 reasons why contact tracing is being challenged right now. And unfortunately, we're hearing at CDC, contact tracing doesn't work, and they don't want to, support that anymore. And I said, that's unfair to blame the contact tracing program that you've put money out towards and saying it doesn't work. First of all, to do any kind of contact tracing, you need a testing strategy. We don't normally, in
Right.
TB and STD, we don't say, oh, you might have this and we're not going to test you. We just want you to go get treatment. We do a little empiric treatment. But so first of all, you need a testing strategy. I think California is leading in that area. Second of all, even if you have a testing strategy, you have to have a rapid case detection strategy. Because again, if the case, by the time you find the case and it's been beyond the quarantine period, why
Right.
bother with contact tracing? And also not all contacts are equal. We're finding a lot of contacts that are being found nationally. I don't know what your data is showing in California that aren't turning into symptomatic cases. They're not the likely transmitters. So we're doing something wrong with how we're doing contact tracing. We may be finding the easy people and we're not finding the people that are transmitting in the community. So you need testing strategies, you need timely case detection. You need a well-trained staff. You can't scale up a contact tracing DIS workforce in 3 months. We're in this for the long haul. That's where my battle is, that we've missed the boat. We got to get this ship, re-energized. And then you've got to have trust in the community. No wonder no one's answering the phones, doing robocalls. That is not the way you engage communities. So we've got lack of community trust. So that's reason 4 that we've got to repair before contact tracing is going to work. And number 5 is you need to look at your phase of the epidemic. We got way too many cases right now in the United States for contact tracing to work. So what we should be doing is targeted contact tracing to get our skills up. And when contact tracing should have worked was in the beginning. And when it's going to work again, if we can get our workforce up to speed, is when we get down and flatten the curve, and then we start seeing outbreaks like they're seeing in Europe.
Yeah.
So we're at the wrong phase of the epidemic, in my opinion.
Yeah. Those are such incredible pearls to leave us on. And I think, Gail, as you may see that there's lots of comments coming in just from people really, really thanking you for being able to be here and come back. You began your career here, and we're so thrilled that you're able to kind of do an ending career thing to inspire us all. So those of us that are still in the field will continue to do this hard work. So I just wanted to really thank you for being able to present. It's really an honor, and we're so happy that you were able to come back.
I have to say, it's my thank you to you guys. You guys are the ones that are doing the hard work. So I really appreciate the opportunity to hear from you. And
thank you so much.
Thank you so much.
What an honor it's been. And I know I'm speaking on behalf of probably everybody on this call because they're singing your accolades. So thank you. Thank you for being here. We know how busy you are, and we truly appreciate you and all of your support to DIS and STD prevention over the years.
Okay. Well, thank you guys.
Thank you. Goodbye, Gail.
Okay. Bye-bye.
Wow, that was truly inspiring, and the depth
know.
and breadth of Dr. Boland's knowledge is amazing. And now I'm going to invite everyone to just breathe that all in, step away from your device for a little bit. We're going to take.
That was nice music. Thank you, Greg. I'm hoping everybody had I see some people not in yet, so I'm hoping, okay. We're seeing some faces. We're seeing people coming back. So Gail's, I know many of us have written about, Gail's presentation, Dr. Boland's presentation, and personally, I miss her. I was quite inspired by what she had to talk about. And again, her commitment and dedication has been inspiring me for a long time. And I know that many of us are, at least for me, this virtual arena is something I'm getting used to, and I'm get confused by on occasion. So I believe as we're coming back from break, I want to acknowledge that we want to hear from the chief of the STD control branch. And so I believe that Dr. Kathleen Jacobson, who I believe is in the room, and I'm looking for,
I'm not seeing her on the participant list, but maybe she's under a different name.
let's see.
She's texting me that she sees you guys and can hear. So this is the joy of technology.
It's a confusing thing, and I will just extend an apology to missing her a confusing email on the timing and having her present on behalf of the Office of AIDS and the STD control branch. So if Dr. Jacobson is
Was that Pike? Do you know what name she has listed or how she's listed? Is it a phone number?
I am trying to figure that out. I'm texting with her now. I think she might be on the wrong Zoom call. So I'm so sorry. I think that's probably what happened this morning as well. We were working it out. Sorry, you guys. I sent her this link again.
okay.
Okay, I'll watch for her in the waiting room.
And just as I mentioned, I think there is some confusion, and we're all getting used to, call it the new normal. So I would like to, extend an apology for any confusion on that, and we welcome her. She should be here in just a few moments.
So how about while we're waiting for Dr. Jacobson, we give some folks time to individually and collectively reflect on Dr. Boland's remarks. And we'd love to see in the chat what resonated with you, for you, in what Dr. Boland said. She had plenty to offer, but a lot of insights, a lot of recommendations, a lot of a vision of the future, a vision of the past. So I want to invite you to enter in the chat what spoke to you as she spoke. All right, what resonated with you? Yes, we see something, the
Dr. Jacobson
recognition
has
that
entered.
destigmatizing language is important.
Yeah, I
Dr.
like that.
Jacobson is in now.
Okay.
So why don't we take a couple moments here? We'll go through the chat and then we'll invite Dr. Jacobson just to speak.
Yeah, I'm only seeing the importance to avoid using the destigmatizing language, and I certainly think that's an important piece. And how she celebrated the work of DIS is often discounted. And she's been a huge supporter of DIS ever since I've known her. And if Dr. Jacobson is here, we welcome you. And again, I want to extend my apologies to you for the confusion in having you present, but we really welcome you now, Dr. Jacobson, to give our people on here a welcome on behalf of the STD control branch and the Office of AIDS.
Okay, great. I'm on. Can you hear
Oh,
me?
thank you. I see you now. Again, apologies, sincere apologies.
Yeah, no worries. Just so long as folks don't know I bailed, or don't think I bailed, but that there was a lot of confusion going on. So, and Dr. Boland, thank you so kindly for stepping in. I'm gonna see if I can share my screen now. Okay, and everybody see that?
Yes.
Yep, and it looks like it's in PowerPoint or presentation mode?
Yes, looks great.
Okay, great. All right, thanks. And thanks, Linda, for the introduction. So I'm gonna talk about the impact of COVID-19 on STDs, HIV, and Hep C, and on DIS in California. And I apologize, Dr. Boland, that I didn't get to see your presentation, so I hope that I don't overlap with you too much. So first, I think you can't talk about DIS and COVID's impact unless you've have a good appreciation for what's going on with COVID. So in California, currently 794,040 individuals who have been diagnosed with COVID, and that represents 3,400 new individuals as of yesterday. Fatality count is 15,398, and that's an increase of 84 from yesterday. Current hospitalizations are 2,474 individuals who are in the hospital with a diagnosis of COVID, and that is a decrease currently of 104 as of yesterday, and in the ICU, 753, which is a decrease of 21 from the day before. Yesterday, or actually 2 days ago, our tests lagged behind by 2 days, our data on our tests. There were 99,390 tests that were performed. And I don't know if you can see this, but oops, I can't see it, but that's a total of over 13 million tests that have been performed in California. And the 7-day positivity rate is 2.8% and 14-day is 3%. So that just your perspective moving into this discussion about how COVID has impacted in California, and looking first at how has it impacted our local health jurisdictions. Pike did this survey for us of local health jurisdictions just last week, and 49% or 30 local health jurisdictions responded. And this looks at what percentage of their staff have been redirected to COVID, and currently remains at 82%, have more than 50% of their staff redirected to COVID. And we've actually done this survey 3 times now, just to try to get a handle on staff availability at the local health jurisdiction. And back in April, you can see that it was around 60% that were 50% or more redirected to COVID. In June, that went up to about 70%. And now, actually, shockingly, it's more at, I'm sorry, I'm trying to shrink down this vision that I have of everybody so that I can see all of my slides, and I keep flipping to the next slide. But now it's 82% have 50% or more of their staff redirected to COVID. And what's happened to STD clinics, in changes that have occurred at STD clinics, prescribing practices have been just minimally impacted. And the light purple is April, this is June, and the bottom line is September. And so as far as limiting face-to-face visits, using telemedicine, and limiting clinic hours, the greatest impact was in June. And now there's a decrease in those areas, heading back towards normal, but still a ways to go, still about 25% or more impacted. Closure of STD services, though, we continue to have a quarter of STD services that remain closed. I think that's all important as we look to what has this done to case reporting and testing for STDs in the era of COVID. Looking first at chlamydia and gonorrhea. And really, I'm just gonna take a second and see if I can somehow, there we go. So I can see all of my slide when I'm talking here. So the orange is chlamydia, the blue is gonorrhea, and this is where the stay-at-home orders were implemented. And you can see a pretty rapid decline in both chlamydia and gonorrhea cases, and then a gradual increase in chlamydia, maybe a slightly, I don't know, maybe a slightly more rapid increase in gonorrhea, maybe because patients are symptomatic, that they started coming back a little bit more, but you can see it's not significantly different. And then if you look at chlamydia and gonorrhea testing in family pack clinics, this data comes from Quest, you can see a significant decline in both chlamydia and gonorrhea testing. And you can also see that that remains low, that that's a sustained decline. And we think that's likely due to the fact for these particular clinics that a lot of those tests are being done for routine screening purposes. And as we all know, there's been a big loss of trust in the healthcare system as a result of COVID. And so likely a lot of individuals are still not coming back for their routine care. So what about primary and secondary syphilis versus late and unknown syphilis? Again, with primary syphilis and secondary syphilis, you see an initial decline after the stay-at-home order and a gradual recovery, although probably not yet back to the baseline. And again, likely due to the fact that these patients are symptomatic, they probably are continuing to seek care. Versus late and unknown, there's a drop, and that drop is sustained. And again, individuals who get diagnosed with late and unknown duration syphilis are often getting this test as part of some form of routine screening. And so again, it's likely that a lot of that routine screening has gone away. And how about congenital syphilis? So again, at the stay-at-home order, we initially see a drop, but then see those numbers shoot right back up to where the baseline was. And this, of course, makes sense because women continue to deliver babies, and we believe that they continue to deliver them in the hospital, although it's unclear if this initial decline here was just normal artifact, or if for any reason some women just decided to stay away from hospitals during COVID as well and delivered at home. We do know that still happens sometimes in California and the US, and it's possible there was more of that. I think only time will tell us if that's the case. Overall, there's been an increase in congenital syphilis cases at 6.7%, but this is not as much of an increase as we've seen in previous years. This is comparing the first 6 months of 2019 versus the first 6 months of 2020. And of course, we would love to believe that that's because you know, we're getting a greater handle on the epidemic, but we are of course concerned that it just represents that it's not being identified and diagnosed as much. We've seen a little bit of an increase in Hispanic congenital syphilis and a kind of equivalent decrease in Blacks being diagnosed with congenital syphilis. However, we're not sure what to make of that because we've seen a fairly significant increase in unknown race and ethnicity data. And finally, those congenital syphilis cases are predominantly occurring in the San Francisco, Central Inland, and Sacramento area. Say that correctly. Oh, yeah, sorry. I think I said that right. Yes. Okay. For what about data completeness? How well are some of the data points being collected? If you look at males with primary and secondary syphilis, the data seems to remain pretty stable on HIV status and gender of sex partners. However, if you look at what happens to that data, when you look at regions, we see that there's a significant decline in HIV status for northern and central inland areas, as well as Los Angeles. Some of the places that have been the greatest impacted by COVID. And for females, again, the status among primary and secondary cases for HIV is pretty stable, we are seeing a little bit of a decline in pregnancy status, and perhaps this is playing a role in some of the decreases in congenital syphilis cases that we're seeing. And looking again, if you break that down by region, we see decreases in northern, in Los Angeles, and the central inland area for both HIV, and then northern and central inland for pregnancy status. What about the impact of COVID on HIV and HCV? The California HIV/AIDS Policy Research Centers did a survey of about 70 help and support service organizations. About 50% of those were in Northern California and 50% in Southern California. Their focus of work was heavily on HIV, but still some significant Hep C and STD work, and populations served pretty, the populations really reach all key populations that we're trying to access: MSMs, trans, women, youth, drug use, homeless, and incarceration. And what happened to their services? We see a significant decline in HIV testing, HCV testing, STD testing, PrEP, as well as peer support, medical care, and outreach education. So after looking at this, as I was putting this together, COVID really has had a significant impact on STDs, HIV, and Hep C. And I think if you look at that, that could look pretty concerning for someone, particularly someone who's DIS, recognizing that, currently 82% of STD staff are being redirected to COVID. Pretty concerning. However, I think that COVID actually brings to us some new opportunities to identify, treat, disease investigate, and contact trace, and to allow us to focus our public health efforts a bit more. And I'm going to go through what I think some of those are as opportunities. So, new opportunities to identify. We've been talking for a little while about doing routine screening in emergency departments. And this is one emergency department that implemented routine screening for syphilis about a year and a half ago. And you can see that although, STD testing rates have gone down in, where routine screening has typically happened, they have not only not gone down, but the positivity rate has maybe gone up a little bit, because this represents March through June of 2020. And this is from Bakersfield Memorial Hospital. Additionally, California and the Testing Task Force recently put out a request for innovations, which is seeking creative ways to reach priority populations and difficult to access populations, to understand how to register and collect specimens in unique ways. And I can tell you, I've seen some of these applications, and there's some very creative ideas out there. How to ensure timely results, ensure state and local health jurisdictions get reporting of those results, that there's linkage to contact tracing and DIS, and ongoing access to care. And it is my hope and my belief that some of these innovations that will be implemented for COVID will ultimately be used for other communicable diseases such as STD, HIV, and Hep C. We've also learned some lessons previously on, in other diseases, on treatment. By now, all of you have seen the HIV care continuum. which this is the 2015 one, at which point 86% of individuals with HIV in the US had been diagnosed, but a significant fewer number had ultimately received care, remained in care, and were on antiretroviral therapy and were virally suppressed. And I can tell you, as an HIV doc myself, you know, we really contemplated for some time, how do we overcome this large gap here, getting to viral suppression? And then hopefully by now all of you have heard of the RAPID program in San Francisco, where they found that if you begin immediate antiretroviral therapy on individuals who are diagnosed with HIV in the hospital, as opposed to referring them to a clinic and waiting for the clinic to begin antiretroviral therapy, that you could decrease their time to viral suppression by almost 2 months. And that decreased time to viral suppression, you know, it really doesn't take a rocket scientist to know that that means fewer HIV infections, because there's going to be fewer transmissions, because the people who are diagnosed are becoming undetectable more quickly. So you are able to very rapidly go from diagnosis towards viral suppression and really overcome a lot of those barriers. So it's really my hope that some of the creative solutions that have been used in HIV can be used in STDs. For instance, you know, for syphilis diagnosis in emergency rooms, it really makes a lot of sense not to try to make patients walk through that care continuum, but rather bring the treatment to them and care for them immediately. There's also significant new infrastructure that's being placed for contact tracing and DIS. I'm sure you've heard of California's COVID-19 contact tracing innovations, which is being led by our own Holly Howard from STD Control, and a number of other individuals from the STD Control branch have or are currently participating in this. And this, they've done significant amount of developing trainings for contact tracing, case investigation for contact tracing, as well as outbreak investigation and management, cultural humility training, and now contact tracing for CBOs and community partners. All of this, you can imagine, can have tremendous impact for other communicable diseases. They've also developed a new data management system called CalConnect, which directly supports case investigation and contact tracing. And they're soon to have a portal for schools, businesses to use for data collection and contact tracing. As well, they've developed a virtual agent app that's on your phone. And basically, at the time that a positive test result is sent, it triggers a SMS notification to the patient to inform them that they can log in and get their results. And also that there's a, when they log in, they can fill out a survey that allows them to input their potential contacts. And that also, based on what those contacts are, it prioritizes who should be called first from a contact tracing standpoint. There are also, they have a frequently asked questions, so patients can also ask and get answers to their questions. And they're currently getting prepared to input a symptom monitoring for patients so they can monitor their own symptoms and determine if they need to go into a hospital or talk to their doc. So again, this app clearly is not going to go away when and if COVID decreases significantly, and it's really an opportunity to use this app, I think, moving forward for other diseases. Finally, there's been a significant expansion of the contact tracing workforce with deploying state staff as well as other local health jurisdiction staff. There's also using state case investigators to mentor these contact tracers, and they're working on strike teams, community engagement teams, and strategic partnerships. And they're looking to see if they can move this upstream as the state implements a state-run COVID-19 lab. They're looking to see if they can actually implement this survey and this app further upstream in the process. I'm almost done. I don't know if I'm getting, somebody's texting me probably about timing here. Just a few more slides. Really, another thing that's come into the highlight is improved precision of disease investigation and contact tracing and public health action. Molecular clusters, which is first something that was beginning to be used for HIV, and now genomic sequencing for COVID-19. Just briefly, typically 4 HIV transmissions are identified per 100 people with HIV per year, or a 1:25 ratio. However, if you actually get into a priority cluster, you can increase that to 33 HIV transmissions per 100 people, or an 8:25 ratio. And an example of this was used in, I just have to see if I'm being asked to, I don't know, sorry. I thought I was getting texts about needing to hurry up. So the-
So we could give you about, can you finish up in about a minute or two? Is that reasonable?
Yeah, I'll be done in about 2 minutes.
Perfect, thank you.
The molecular cluster was used in San Antonio, Texas, where they identified 24 individuals that were linked by genomic sequencing. That resulted in them finding 87 individuals also linked to that same cluster. And that resulted in local health jurisdiction action to put out alerts to providers about HIV diagnostic testing, acute HIV PrEP, and redirect funds to access PrEP, and to make this community a fast-track city. And here at CDPH is COVIDNet, which I've participated in with our VRDL lab director colleagues. And COVIDNet uses molecular clusters, also known as genomic sequencing, to estimate the size of outbreaks, identify the actual direction of outbreaks, flag other exposed communities, and focus target public health action. And one example is this cluster right here, which helped us realize that it sort of linked us to another, one individual to another group of individuals, and allowed us to find a significant group of individuals that were also infected. And that's one of the powers of genomic sequencing, is to improve the precision of public health and also be able to determine the direction of transmission, characterize the size, and then we can monitor changes of genomic sequencing, which might give us indication that the virus is changing, either to be more virulent or less so. So in conclusion, we really do have some new tools in our toolbox. Although COVID has had a significant impact on STD, HIV, and Hep C, these new tools in our toolbox, if we use them and if we can move some of them from COVID to STD, HIV, and Hep C in the future, can help us better identify, rapidly treat, use innovations for contact tracing and DIS, and more precise public health action. And this really is an opportunity in this difficult time to potentially significantly streamline DIS work in the future. And that's it.
Thank you so much, Dr. Jacobson. This was really fascinating for, I think, all of us to gain an understanding of these tools and the opportunities while looking at, how to balance the challenges that COVID has presented. I think I'm liking this. I think there's a positive spin if we can take the opportunity to look at what we can benefit by looking at the different apps that are out there, or how to help with this molecular clustering and genomic sequencing and relating that to the other diseases. Hopefully that will help in all of our jurisdictions, especially based on some of the data that you described, where 50% of most jurisdictions are not losing their staff, but their staff are being reassigned to COVID. So I really appreciate hearing your talk, and I know there were some comments coming in, but I just appreciate this, and thank you for being here. Eileen, I didn't know if there was anything you needed to.
No, thank you. I think we get to invite Dr. Rutherford on now. Thank you, Dr. Jacobson. Appreciate your time and your wisdom there.
Okay, thank you so much for that presentation. I think we still have, so much to learn here in the areas of DIS and the impact of COVID and the relationship with STDs and HIV and other diseases. And now I have the honor to introduce Dr. George Rutherford. And Dr. Rutherford is the Salvatore Pablo Lucia Professor of Epidemiology, Preventive Medicine, Pediatrics and History, and head of the Division of Infectious Disease and Global Epidemiology in the Department of Epidemiology and Biostatistics, University of California, San Francisco. Educated at Stanford University and Duke University School of Medicine, he is board certified in pediatrics and general preventative medicine and public health. His expertise is in the epidemiology and control of communicable diseases of public health significance, with a focus on HIV, Ebola virus, and Zika virus infection in low and middle income countries. Dr. Rutherford serves as an advisor to the Center for Disease Control and Prevention and the World Health Organization. He's been involved in the public health response to SARS-CoV-2 since the earliest days of the pandemic. And based on discussions with my colleagues, we know that this bio is impressive, but it doesn't give the full picture of his breadth of experience and expertise. He's worked in the middle of many disease responses, such as Ebola, with his sleeves rolled up to assure success. Dr. Rutherford is a highly sought after speaker these days. You probably recognize him as he's been all over the media talking about COVID. And we're lucky and very grateful to have some of his valuable time. So we hope he'll share some of his stories from the field. So welcome, Dr. Rutherford.
Thanks very much, Linda. It's great. It's great to be here. I have very fond memories of all the DISs I've worked with over the years, and it's great to speak with all of you. I've had a massive computer meltdown this morning, so I've asked Greg to share my slides and run the slides for me. If you please, Professor. I've always wanted to say that. So I thought I'd talk sort of the broader picture of contact tracing and disease investigation and communicable disease control. The next one, please. And I think these are some basic questions, and it's sort of, I think, useful to kind of put everything out in front of us so we understand what subset of stuff we're talking about. So communicable diseases is, as they imply and as you guys work in every day, is a disease caused by an infectious organs or its toxins, like diphtheria and tetanus. It can be spread from person to person, animal to person, animal to animal, or person to animal, either directly or indirectly, like through contaminated food. We have a number of tools that we can use to prevent communicable disease. And I'm not talking about treatment, I'm just talking about prevention here. We have personal measures such as personal hygiene, in this case, washing hands. We have protective barriers, and just think of the drapes in the OR when surgery goes on, to condoms, to, you know, whatever. We have avoidance, and I am asked by interminable numbers of people, well, you know, I realize I'm 85, but I really want to see, you know, something, and I can't get the yellow fever vaccine. What should I do? And I say, don't go, you know, avoid it, right? So it's the same thing, you know, you want to go, I know we all want to go to indoor restaurants. Think twice. We can interrupt transmission of the agents through case finding. That is, we can do presumptive treatment of cases and contacts like we do in STDs. We can do isolation and quarantine like we're doing now for COVID and have done for SARS in the past. We have pre and post exposure prophylaxis. We have vector control. We have environment or habitat control, which is really important for vector-borne diseases. We have aseptic technique, again, hugely important for surgical infections. Sanitation and water purification are probably the greatest things that public health has ever done. Most of it was done in the 19th century. And we have food hygiene. And then finally, we have inactivation. We can physically inactivate things through cold heat or radiation. And we can also do chemical disinfection. And so the ones that I've put in red italics are things that apply to COVID-19. Radiation is UV radiation, which is being employed as something to clean things with. But you know, the real thing that we do is that we find cases and we isolate people during their infectious period. Next one, please. So why do we want to find cases? Well, we want to isolate those who are already infected and are infectious. We want to quarantine those who've been exposed and may become infected and infectious, and I'll speak more about that. We want to treat those who are already infected, and we want to presumptively treat those who've been exposed. These last two bullets are what we do every day for syphilis and other STD control. Case finding refers to an active process of attempting to identify cases either through testing or other screening techniques like fever checks, which by the way don't work very well. And then cases can be identified when they're diagnosed with the disease or in screening programs if infection is asymptomatic or pre-symptomatic. And remember, with COVID, we're dealing with a disease in which 40% of infections are asymptomatic. And even more bothersome is that if you look at the 3 days people are most infectious who develop symptoms, which is days 4, 5, and 6, on day 4, they haven't developed symptoms yet. So overall, if you think of the days that people are most infectious, days 4, 5, and 6 post-exposure, fully 60% of people who are in those 3 days have no symptoms at all. Everybody, all the 40% who never develop symptoms, plus a third of the 60% who develop symptoms. So I did that as a back of the envelope calculation when CDC put out its advice to not bother to test people who didn't have symptoms. What? Next one, please. So just language, we have cases or primary or index cases, and then contacts, which are secondary cases. The next one, please. And then contact tracing itself is a process of identifying people who have come into contact with an infected person and subsequent collection of further information about them. By tracing them, testing them for infection, and isolating, especially isolating or treating them and tracing their contacts in turn, we aim to reduce infections in the general population. And this was laid out in a remarkable book, which I had the pleasure of reading once, written in, I think, 1938, although it's so blurred out, Shadow on the Land, by Thomas Perrin, who was the Surgeon General. He became the Surgeon General. I don't think he was Surgeon General quite yet. He was head of the Bureau of Venereal Diseases for the U.S. Public Health Service. And they were very concerned about syphilis in terms of troop readiness, because in certain Army bases, large proportions of the troops had venereal diseases, had sexually transmitted diseases, and were unfit for duty. The next one, please. So for what types of diseases do we use contact tracing? Well, obviously the STDs you guys work on all the time. I've been involved a lot with trying to set up HIV contact tracing programs in Africa, which are in which the index cases are not HIV cases, but they're cases that test for which we have markers of recent HIV infection. So it's almost like an IgM for measles or something like that, or high titer syphilis. We have respiratory diseases, TB, measles, COVID, SARS. We have parenterally transmitted diseases, HIV, Hep B and C, and Ebola. Ebola really is a parenteral infection because it involves blood-to-blood contact. And contact tracing was massively important in stopping transmission in this last outbreak in the far eastern Democratic Republic of Congo. And just remember that we do have, that Ebola is A, a treatable disease, and B, a vaccine preventable disease now. And so doing contact tracing is a way to get the drugs and the drugs to the right people and the vaccines to the people around them. So this is distinct from outbreak investigation, where people who've been exposed are contacted for diagnosis, treatment, isolation, and quarantine as appropriate. And it's as opposed to outbreak investigation, which tends to be a kind of one-off deal. Contact tracing is a routine, ongoing routine activity. Next one, please. So I thought it might be useful to say, what's the difference between sexually transmitted diseases and respiratory diseases in terms of contact tracing. For sexually transmitted diseases, the emphasis is on prompt identification and treatment before other people get infected. It attempts to reach infected contacts during the disease incubation period before they can spread the infection further, and to treat them. We're dealing with relatively small numbers and relatively more identifiable contacts than with respiratory diseases. With respiratory diseases, there are multiple emphases: with diagnosis and treatment, like for TB, with post-exposure immunization, like with measles, and with isolation and quarantine, like with SARS and COVID-19. There's potentially a much larger number of contacts who are less readily identifiable, although I'm sure you would all argue with me about how identifiable a lot of the sexual contacts are. And contacts can be exposed to a wide range of doses of the agent. You can have people who are coughing right in your face, to people who are sitting 6 tables over in a restaurant with a bad air conditioner. So you can have different levels of exposure, different levels of inocula. The next one, please. This is my favorite outbreak. And I think some of you may have worked on this. So, you know, at Amusement Park A, otherwise known as Disneyland, there was a big outbreak of measles in December, with exposure in December, and cases that went on through a couple of generations of transmission out into February. This involved mostly unimmunized kids, although there are always a few vaccine failures in these things. But this is an example of where we want to do contact tracing. You imagine how easy that is at Disneyland, although I do guess you have credit card receipts so you can run down the 25,000 people who came there that day that the exposure occurred. You can imagine how easy that is to find those people. But here with measles, because measles vaccine virus has a shorter incubation period than wild type virus, you can use immunization as post-exposure prophylaxis, kind of like we do for rabies as well, and tetanus. So you can give people the measles vaccine shot after they've been exposed, right, and prevent or at least ameliorate the clinical case of measles. Next one, please. So just these things are words that get thrown around now a lot. And we go to great pains to differentiate among them in our group at UC San Francisco. And we work a lot with the city and county of San Francisco, as well as with CDPH. So case investigation are of index cases. You get reported, you get interviewed. We want to know about your exposure. We want to know about symptom onset and diagnosis. We want to know about what your need for care is, who your close contacts are, what type of exposure was there, and what the duration of exposure was. Contact tracing is of the contacts of the cases, right? We want to confirm that they're in contact with the index case, and we don't ask outright, but about 80 to 90% of the case of the index cases give us permission to use their names, and we in fact ask them to call their contacts beforehand. The type of exposure, the duration of the exposure, and then whether they're symptomatic, whether they've been tested at all, and any kinds of preventive measures, which in the future here will be, for COVID, will be immunization. But this is just a sort of generic thing, general. Isolation, removal of infectious individuals from contact with susceptibles. In San Francisco, hotel rooms are used a ton for isolation. And quarantine is removal of exposed but not yet infectious individuals from contact with susceptibles. And then the whole response thing can include additional localized or network case finding or testing, immunizations, and things like chemoprophylaxis, like for meningococcal disease. My youngest daughter was a freshman at a school back east that had had a big meninge B outbreak. And my wife was going to kill me, but I got to ask we got to go to a freshman parents thing. And I asked the president, like, why they were mismanaging their meningococcal disease outbreak. And it was so lame, it was so lame. So the minute I walked out of there, I went and wrote a prescription for ciprofloxacin and gave it to my daughter. But they were sitting around waiting for the meninge B vaccine to come in to get licensed, which eventually happened, like February, March next year. And then everybody got the vaccine. The next one, please. So this is hard to graph because it's so much going on. But if you think of a triad of case investigation, contact investigation, and then public health action, the cases and contacts would be isolated if they're in fact cases. You quarantine contacts, and then public health action can include additional case finding, chemoprophylaxis, immunization. The next one, please. Now, one of my big complaints is that we quarantine too many people. And this was true in SARS in Beijing in 2003. Overall, they quarantined 151,000 people in Taiwan. Well, there was also one in Beijing. In Taiwan, 151,000 people and had 24 cases. So that's 0.02. So they unnecessarily quarantined 5,000 people for every one additional case. Okay, that is not what needs to happen. We need to be much more specific in our diagnoses of close contacts. And I'm very concerned about these proximity apps that say, oh, you were in contact with so-and-so, you were in contact with a case. And there may have been a wall in between you, for God's sake. And they may have, or maybe you had masks on or whatever. In Beijing, there was a study specifically done in the Hainan district of Beijing, and only 2.9% of people who went into quarantine actually eventually developed disease. I think, we got to have a much higher hit rate than that, especially given the demographics of COVID right now, where, these are poor people who are blue collar workers who are really living paycheck to paycheck. And unless there's a income replacement program, as has been in San Francisco, where they're going to get their income replaced, there's going to be no incentive for them to go into quarantine or to isolate, especially if they have asymptomatic disease. But really with quarantine, quarantine is going to get a real bad name. And more to the point, they're going to get quarantined over and over and over and over again because they're coming from communities with a lot of transmission. The next one, please. So what are we trying to accomplish and not accomplish? So the things we're trying to accomplish, the good things, right, are diagnose and isolate people who are infectious, right? To identify and quarantine persons who've been exposed, although isolating the infectious during the period of time they're infectious is the most important thing that we can do. We can provide them services when they need to isolate or quarantine. Housing, income support, food and other support as they need for the patient, him or herself, and their family, if they have family here. Right? You're going to take somebody out of the household, the dad, say, out of the household, and put him into a hotel, and the mom's not working, somebody's got to buy food for that family. The bad things we do is we isolate people. I think the bad things we do, we're trying not to accomplish, is to isolate people beyond when they're infectious. And PCR is very useful for diagnosing acute infection, but it's not predictive at all of when you're no longer infectious. And will, at least fecal PCRs will continue to be positive for, I don't know, weeks afterwards. Where, you know, all the one real definitive study would say that you can't recover any virus at all beyond 8 days post symptom onset. Then we're also quarantining people at low risk of actually having been infected unnecessarily. And we're extending quarantine beyond a period of maximum infectiousness. Remember that the days you're most infectious are days 4, 5, and 6 after exposure. So why are we quarantining for 14 days? I mean, I know why we were, because that was the range of the 95% high end of potential incubation periods that were reported from China. But I think it's time to take a long relook at that and see if we can get a better, tighter estimate of how long you really need to quarantine people. The next one, please. And this is just some SARS diagnostic stuff that I think is helpful, and people are more than welcome to these slides. But this orange line over here on the second one that comes up, that peaks out, that's really viral load. And, you know, viral load is really high on days 4, 5, and 6. It's not that high any longer, and it starts to drop off. Now, okay. If you're in some ICU disaster with bad pneumonia and ARDS, you can be infectious for longer, but that's because you're instrumenting the lungs and finding, tiny viral particles, tiny droplets deep down in the lung tissue. But in general, I think that these are the 3 days that you're most infectious, and we need to be cognizant that you don't need to be isolated or quarantined nearly as long as we are having people do. Antibody testing swell. We love antibody testing in epidemiology. It's of no use for acute diagnostics. Okay, the next one, please. All right, so just to say a few words about contact tracing here in the city, in San Francisco. Next one, please. Here's what the epidemic curve looks like at San Francisco, with an early peak in April and May, drops down in early to mid-June, and then takes off again July and August, and then starts to come down in August and into September. If you look across the entire country, there's pretty clear evidence that there's a third wave that's about to start. The next one, please. This just shows you some of the demographics. In California, pay attention to the upper left-hand corner where you can see the Hispanic or Latinx cases constituting more than half. The other thing that's interesting is that we're seeing younger patients as time goes on. MMWR this week had a breakdown of cases by time of infection, like by month of infection, and by age group, and there's a clear shift to younger ages. Okay, next one, please. And just in San Francisco, it's kind of obvious where the cases are going to be. They're going to be where the patients are, and the patients are in the southeastern part of the city. In large part, the Mission, the Outer Mission, Excelsior, Viz Valley, Bayview, Hunters Point, but then also to a lesser extent in the Tenderloin and the dark blue in the middle, and in the south of Market area. But it's pretty clear where the cases are occurring, where the transmission's occurring. And actually the city health department has block by block data of where there are cases. And there's some blocks in the Mission where there are 40% of people have been reported. Now that's with a lot of intensive case finding, but you can really hone down your disease control programs in those situations. Next one, please. So how do we try and make this happen? There's obviously, in contact tracing, there's a huge thing about cultural sensitivity. And I was delighted Dr. Jacobson mentioned some of the modules on cultural humility, among other things. We need Spanish-speaking contact tracers and team clinicians. We are acutely aware of and address language and cultural barriers. And some of the other things that we need to worry about in this population are scams. Scams are aplenty. Immigration worries. The last thing you need is ICE trailing you around. Unemployment, having people lay out of their jobs and then them not being able to get them back. A real big problem. And then access and navigation of healthcare services, especially if they're uninsured. The next, please. So there's this whole construct of wraparound services in DPH with isolation and quarantine rooms, hotel rooms, food service, cleaning supplies, medication support for other services like addiction and substance abuse. If you're on methadone and they lock you up in one of these hotels, somebody needs to bring you your methadone. And income maintenance and the right to recover program, as I mentioned. The next one, please. And then finally, there's the whole issue of isolation and quarantine and social services. So if contacts cannot self-isolate or self-quarantine, not everybody has Chris Cuomo's basement. They're referred for isolation and quarantine facilities in hotel rooms. Symptomatic cases who do not require hospitalization, but to get visited. Symptomatic contacts who do not require hospitalization, who live in congregate settings or on the outside. People who require hospitalization, who do not require hospitalization, who live in congregate settings, whether they're contacts or not. And asymptomatic contacts who live in congregate settings or outside in SROs with shared bathrooms. So we're trying to get these people who are the most vulnerable and the most likely to develop disease into isolation and quarantine facilities. The next one, please. And this just gives you an idea about some of the bed space available. So there's hotels, congregate things, the isolation and quarantine hotels, and trailers as well. And then there's some other additional ones that are they're under preparation. This gray in the right-hand panel. The next one, please. And this just shows you who's ended up in these shelter-in-place programs in the hotels. You can see how they're older, 51 to 60, and a lot of these people were unsheltered at the time they were admitted. And we were trying to pull very specifically the frail homeless off the street and get them housed. The next one, please. So I'm happy to answer any questions, and it's a delight to speak with all of you.
Thank you, Dr.
Great.
Rice.
Oh.
Go ahead, Linda.
Go ahead. Well, thank you, Dr. Rutherford. That was really informative. And I know we do have a number of questions in the chat for you. And so I will ask colleagues to help to make sure I'm capturing most of this or some of this. I think one of the questions, there was first a comment about with flu season coming, we're concerned about how flu symptoms overlap with COVID symptoms.
Mm-hmm.
May mean people are quarantined longer than necessary. Mm-hmm. Widespread availability of COVID-19 rapid tests. So that was that. And I guess a follow-up, the question around that might be what recommendations for quarantine do you have given current testing limitations? I know you've said that we're quarantining too many and we need to be more specific, but do you have some recommendations if testing is limited?
Well, I mean, if the people who go in quarantine test negative, right? So if they're positive, they go into isolation.
Right.
So that doesn't bother me that much. But I mean, I think if you have to assume if you can't test them, and they're truly close contacts, seeing somebody across the cantaloupe aisle at Safeway is not a close contact.
Mhm.
You got to basically be living with them and eating with them. And I mean, I know we say 6 feet, 15 minutes, or 30 minutes. There are a couple of different definitions. People don't pay. Masks aren't part of those definitions. I think we've made the quarantine definitions too sensitive and insufficiently specific. And given that quarantine comes at tremendous cost to individuals,
Yeah.
I mean, yeah, I'd like nothing better than to lounge around for a couple of weeks and watch TV, but I can afford it. If I can't afford it, I'm hosed, right? It's just brutal. So I think we have to be really specific about it. And if we're going to ask people to do it, we need to be able to support them and make it non-punitive. Basically provide them what they need to live and to replace the income they're not getting and to protect their jobs out the other end. So those are my thoughts on it.
Yeah, and some of those are larger structural issues, right? That in certain areas, there's not going to be that luxury, but I appreciate hearing that. And I know that we don't have Dr. Bolin on the line, but it says, will CDC change the quarantine guidelines? I think many of us operate under, the guidelines put out by the CDC. And
yeah. So considering Gail and I were EIS officers together, and I've known her longer than her husband has. If she were sitting there, I'd say, you guys need to take a relook with more recent data at how long you're suggesting people isolate and quarantine, especially with this realization about viral loads and cycle times with PCRs and all that stuff that would suggest that really the period of time that people are hyper-infectious is pretty limited. It's certainly not 2 weeks long. It's like 3 or 4 days, right? But on the other hand, because it's so early on in infection, there is a huge premium on finding people rapidly. If you're finding them 5 days later, school's out, doesn't matter.
yeah. Speaking of being in school, there were some questions about thoughts on testing kids younger than 6. If you have any thoughts on that.
Yeah, you can test kids at any age. I mean, my colleague, Dr. Maldonado at Stanford, said she did anterior nasal swabs on sleeping newborns and didn't wake them up. So it's there you go. So you can test them at younger ages. You can certainly do anterior nasal swabs. You can do swabs of the sulcus, do salivary tests. It all works okay. You just need an adequate sample, and you don't want to torture them. Say I as a pediatrician. That's a good watchwords of pediatrics. Don't torture the children.
Do you have recommendations? Another question in the chat for how often folks who work with the public and interact with new people on a regular basis, how often they should be tested?
No, I mean, it depends. It all depends. I mean, if you're talking about people who are really in close contact, like, people working at a community clinic in the Tenderloin or something, yeah, they should probably be tested with some frequency. At UCSF, we're doing, so medical settings are kind of a different beast. If you're talking about bus drivers and the police and stuff, I think I'm not a big fan of mass testing. Although as the technology evolves, I think that it's going to be a much more important part of our armamentarium than it has been in the past. It's been used diagnostically, largely in the past, and but I think now that with the stellar example set by the National Basketball Association and Major League Baseball and stuff about frequent mass testing, which is starting to bleed over onto college campuses.
Yeah.
I think that we may be able to do it. It may become more important. And I know at least in San Francisco, the city health department's really interested in doing frequent testing in schools. to rule out. If I were going to do that, I'd start in high school, so I wouldn't bother a lot with the little kids.
Several other questions in the chat about reinfection or second infections. We've heard a lot about antibodies may only last a few months.
Right.
Thoughts on that?
There's good data recently from Vanderbilt. There's that showed declining 58% decline in the proportion of healthcare workers that had measurable neutralizing antibodies over 2 months. So you lose almost 60% of people lose measurable neutralizing antibody over 2 months. That's not good. And we now have 4 cases of reinfection that have been reported roughly around 2 to 4 months post their initial infection, and these are clearly documented. They're different strains, so it's clearly documented. So that would suggest, and we know for the alpha coronaviruses, the ones that cause colds, you lose immunity after about 4 months. So it's all seemed pretty consistent. So yeah, so so people say, oh well, this part of New York City has antibody prevalence of 30%. We don't really need to get vaccine. That's nonsense. I think you have to assume that nobody has neutralizing antibody at this point in time. Now, how are we going to get around that with vaccines? Because the vaccines are going to be will be continuously producing antigen, especially the mRNA vaccines. They'll be continuously cranking out little bits of spike protein that you'll continuously make antibody to and will continuously stimulate the immune system. So it's like getting a constant booster, kind of a trickling booster dose.
Can you talk a little bit more about antigen and POC testing?
Yeah, so antigen testing its time is coming very quickly. Antigen testing is, you can do it with saliva, you can do it with sulcal swabs. It doesn't have as high sensitivity, maybe 94% as opposed to 99. But if you do it frequently enough and have a cadence of every couple of times a week, it works just as well in detecting people, because what you're trying to detect is that period of very high viral load, and it works just as well. It also costs $5 as opposed to $100 and something. So there's it's becoming popular as an alternative. There has not been a home-based antigen test approved yet, I don't think. I'm not sure. Let me take that back. The ideal thing would be to have something colorimetric that you could do at home based on saliva or a sulcal swab, and that you could send, and then it reported it back somehow centrally, because you have to feed it through your phone or whatever. It'd be like a pregnancy test. Would have that that's the ideal thing, right? So we're getting there. Point of care tests for PCRs work well. They perform perfectly well, but they work on one specimen at a time. So with a 15-minute turnaround, that means you can, if you have to screen 4 people an hour, okay, that's fine. You have to screen 400 an hour, it's not fine, right? So it's really one-to-one stuff.
Well, I think we have time for one more question, and it looks like there's something. What should we tell patients about aerosol transmission?
Aerosol transmission is real. I mean, so leaving aside the ICU, okay, let's just leave that aside. If any of you are working as in intensive care units, in whatever capacity, wear your PAPRs, pay really close attention, because aerosol transmission really happens in ICUs and ORs and emergency departments where people are being intubated. Aerosol transmission is a real phenomenon. It's just, I don't think it's that common. There are a handful of cases that I could point to where it's really clear aerosol transmission. However, all the cases have been in the spring and summer. As we start coming back inside, we may see more cases in which are clear examples of aerosol transmission. ASHRAE, my favorite organization, the American Society of Heating, Refrigeration, and Air Conditioning Engineers, has just come out with new standards that say, basically they say, do 6 air exchanges per hour. do complete exhaust. So don't recirculate any air. Every new air intake is with outside air, no recirculated air, which is hugely energy inefficient, as you can imagine. But you're not recirculating air. So it kind of makes the aerosol problem go away to the extent it can. And the other thing they're talking about is much higher level filtration on air exchange units. So, I mean, I'd be slow to go back into indoor spaces unless you know that they have really modern air exchange equipment, and you really want to be there.
Yeah, that's going to be a challenge. I mean, we're pretty lucky here in many parts of California where the weather's pretty temperate, but it'll be curious to see what happens as we're moving into colder weather.
To which I reply, don't be a baby. In 1918, 1919, all New York City schools are outdoors. You have pictures of these kids with like 3 pairs of mittens on, right? And so don't be a baby. Yeah.
Bundle up, be out.
Invest in winter coat manufacturers, right?
Yeah, no, they get down at Burlington Coat Factory there on Market Street. We got some stuff going for you.
Go shopping, get your winter gear. Well, thank you so much, Dr. Rutherford. This was really interesting and informative. And as mentioned, we really appreciate your time and sharing of your experiences.
Oh, it's my great pleasure.
Yeah.
Take care. See you later.
Thank you.
Bye-bye.
Bye now. All right. So Greg, I think we can just do a stop share there. I can't see, I mean, we're at the end of our first day of